Hi.
Sir, we are live now. Good to go, sir.
We are live now, sir. Michael, sir. We are live now. Sir, you are muted, sir. Michael, sir, you are mute.
हेलो गुड इवनिंग सर
हेलो हेलो
ठीक है सर
Hello, how are you?
आई एम गुड सर हेलो प्रभाकर सर गुड इवनिंग
हाय
सर
हाउ आर यू
प्रणाम सर
नाइस टू सी यू गुड आजकल तो यही तरीका है बात मिलने का और बात करने का
प्रवीण सर आई थिंक हाउ विल स्टार्ट सर डॉक्टर सुषमा हेलो ओके हेलो प्रवीण सर ओके
Hello, hi Manish, how are you doing?
आई एम गुड सर आई एम गुड
Good evening, doctors. On behalf of INTAS, I welcome you all for this live webinar on real-world experiences of Perampanel. We are very glad and honored to have with us the speaker for today's event, Dr. Atma Ram Bansal, who has very gladly consented in such a short notice to take up this webinar for the cause of the medical fraternity in the treatment of the epilepsy patients. I call upon Dr. Atma Ram Bansal to please introduce Dr. Praveen Gupta for this program. Thank you.
A very good evening to everyone, and on this Saturday evening, we hope to discuss about this molecule Perampanel in a very informative way. We should be able to learn from each other, and to moderate this session, we have none other than Dr. Praveen Gupta, a very close friend of mine, and working just 2 kilometers and staying just 2 kilometers from each other. And he's practically the first and the most prominent neurologist of Gurgaon. I think now more than 14-15 years, if I'm not wrong. And he's working at Fortis Gurgaon as head and director. And he's a very kind of a most active neurologist even now in Gurgaon. So he's having keen interest in academic things and discussions, and a very kind of gel kind of a person whom you can easily gel. And he's that the character is he's never seen angry actually by anyone. So a very smiling person, very interactive person. So please start your moderation, Dr. Praveen Gupta.
Thank you, Dr. Atmaram, for such a generous introduction. I will now invite Dr. Sushma Sharma to introduce our chairperson, Dr. Parvesh Shah, as he happens to be her guide, and it is most appropriate that he introduces him. Dr. Sushma, please.
Thank you so much, Dr. Praveen and Dr. Bansal, for agreeing to my special request to allow me to introduce Dr. Parvesh Shah, As you have already told, Dr. Parvez Shah has been my teacher and mentor during my MD medicine days, and he has been the first neurology teacher of mine. And it is under his guidance that I developed interest in neurology, and it is under his patronage that I took my first baby steps in neurology. And today, after 14 years, I get to share this platform with sir, and it is a very special moment for me. Sir, my respect and regard for you has only increased with the passage of time. So to introduce esteemed seniors and friends, now to introduce Dr. Parvez Shah. Do we have a slide, Parveen sir, or shall I say
extempore? That's
right. No problem, sir. So Dr. Parvez Ahmad Shah is a very eminent neurologist from Srinagar, Jammu and Kashmir, which is my home state also. Sir has been a teacher and mentor to many students like me. He has been a professor in Government Medical College, Srinagar. He is DM in neurology from PGI Chandigarh, and a very crisp thought process and very precise kind of communication. Sir has, most of us know the science of neurology, but I have seen sir practicing the art of neurology. He is an inspirational figure and he has inspired many like me. It's my proud privilege to introducing you, sir. Thank you.
Our next chairperson is Dr. Sudesh Prabhakar, formerly the head of neurology at PGI, a very astute clinician and a revered teacher by all of us. Currently, Dr. Prabhakar works in my Fortis Fellow Hospital in Mohali. He's the head there, and he still continues to be an astute clinician, guide and aspire many young budding neurologists like us. Welcome, Dr. Prabhakar, to this seminar on Perampanel.
Thank you. Thank you.
Dr. Prabhakar, can I have your opening remarks on the topic of today, which is Perampanel in the clinical practice?
Yes, I think this is a good molecule. However, when it came in the market, the price was prohibitive. We will discuss our experience later on. It definitely helped people to whom we gave. And there were problems in the few which we need to consider. And one of the major problem was the cost. I think the cost having been taken care of, this molecule, though many people have been saying that it is a broad spectrum sort of anticonvulsant, but I think we have to discuss that point also, because I have seen people using it as a second add-on drug after the first ones. That point also needs to be discussed today, and then we'll see how the things move on. Thank you very much.
Thank you, sir. We will discuss all the points that have been raised by you appropriately. And now may I invite Dr. Parvez Shah to give his opening remarks on the subject of Perampanel and its value in clinical practice. Dr. Parvez Shah, please.
Thank you. Good evening to all of you. First, I am thankful and my good wishes to my mentor and teacher, Professor Prabhakar sir. He is the inspiration in neurology, and I have been a student in 95. I passed DM. He was my teacher that time, and he continues to be my teacher. Secondly, I am thankful to Dr. Sushma for her generous introduction. Now, so far coming to the topic, so far as Perampanel is concerned, it is a relatively new molecule. Although it's not really new, but it has come to the market a few years back, but it did not pick up as much as it was expected. The main factor being the cost. Now, as Dr. Prabhakar said, the cost factor has been taken care of. So far, this molecule is concerned, is primarily used as add-on therapy in refractory epilepsy. And the main indication of this molecule is focal seizures or focal seizure with secondary generalization. We can use this molecule in patients with LG syndrome as well, but again as an add-on therapy. Although all of us have some experience with this molecule, but the main drawback with this molecule was sedation, somnolence, which I have come across in my patients. And in most of the patients, I had to discontinue it primarily because of cost factor, and secondly, because of this untoward effect. And mainly it was the somnolence. Although there are many more untoward effects, which we are going to discuss in due course of time. But I think it's a promising molecule. And in India, the molecule has been licensed above the age of 4 years, but FDA has approved it above the age of 12 years. So most of the patients we have to use in pediatric population here. And as we know, epilepsy is primarily a pediatric disorder, although it has a bimotor distribution. But it is licensed in India, as I mentioned, above the age of 4 years. But in FDA has approved it above the age of 12 years. But again, I think from India also, there are very limited studies so far its usage is concerned. I think we are going to discuss in due course of time, and things will unravel once we discuss among the panelists. Thank you.
Thank you, sir. As you rightly said, we may not have so many studies, but we have many astute neurologists here in the panel today who will share their experience in our own setting to guide us. But before that, it is my pleasure to invite Dr. Atmaram Bansal, a very dear friend of mine and a very astute epileptologist. Most of us present here are actually doing neurology and epilepsy together. But Atmaram is one of the few neurologists who does epilepsy as his primary passion, and he does it very passionately and eminently. He has written many chapters in books, conducted many EEG workshops, is a part of most of the bodies on epilepsy, and is a contributor to epilepsy development research in this country. So with pleasure, I invite Dr. Atmaram Bansal to enlighten us about Perampanel before we start the panel discussion. Dr. Atmaram, please.
Very good evening to everyone. And as our presentation today is about Perampanel, so without wasting time, I'll directly go for my PPT. And I hope this is visible.
Yes.
I'm audible.
Yes.
Okay, great. So as we know that Perampanel is available in India for last 2 to 3 years, and we have been using it off and on, and were not able to use it primarily because of cost factor. And my role is to first bit of discussion about what is this molecule about, and then its role in refractory epilepsy. So as we know that roughly 1/3 of the patient we are not able to manage. So whether we give 1 medicine, 2 medicine, 3 medicine, 4, 5 medicine, easily 1/3 of the patient we are not able to manage. And this is actually one of my area of interest. I deal with the refractory epilepsy. So about the drugs, you must have seen these slides in many of the meetings. So these are 2 drugs which are recently introduced, and the couple of months back became generic, and now Perampanel, which has become generic. And the best part is that this is in last 20-30 years that we are getting so many drugs. So we hope that with these kind of research, maybe someday we have even a better drug acting on a different molecule like this Perampanel. So from epilepsy point of view, we should know this particular structure about this postsynaptic vesicle. And the postsynaptic, mainly it is glutamate receptor. So glutamate is kind of released from the presynaptic vesicle. There are some excitatory neurons and some are inhibitory like GABA. Most of those drugs, the first generation drugs act on GABA. And now there are newer drugs like one which acts on SV2, which is levetiracetam and brivaracetam. And this glutamate, not per se, but on the glutamate receptor. So there are 3 types of glutamate receptor, AMPA, NMDA, and kainate receptor. So when we come to these receptors, which is mainly AMPA receptor, which is responsible for fast activation of the postsynaptic vesicle. While the NMD has mainly role in kind of slow kind of release, and NMD is more involved in learning and memory rather than in kind of epilepsy. So AMPA receptors are quite abundant, and they are on the excitatory synapses, and they are fast synapses, and they are a first component to generate excitatory postsynaptic potential. And when this potential is more, then it generates excitatory. This is how it happens. The more the glutamate is there, the more number of receptors are open, and then EPSP creates action potential. This is a simple kind of a presentation for AMPA receptors. So see that if we kind of try to see in an artistic way. So suppose this is the AMPA receptor. So what happens in a normal state when it is inactive, it is closed. So there are 2 binding sites. This is glutamate binding site, and this is non-competitive binding site. So when the glutamate is available, this opens the channel and sodium channels are then going inside. So what happens in normal situation, glutamate is away, then it doesn't kind of activate. When the glutamate reaches the receptor, it is open and the sodium is able to kind of go inside and it starts producing action potential. So in a normal scenario, once the glutamate is not there, then again it gets closed. So what happens when glutamate is blocked by some kind of competitive antagonist, then this channel can't be opened and sodium channel will remain closed. So what, suppose the glutamate is too much in number and what some antagonist we are giving, so that is replaced by number of glutamate molecules. So this is competitive antagonism. So in this case, it can be replaced if the glutamate is released significant amount from the presynaptic vesicle. So to prevent that, the best thing is to have something like non-competitive antagonist. And non-competitive antagonist will not have any impact on the number of glutamate available. So whatever excitation level is there from the presynaptic vesicle, if the postsynaptic vesicles are blocked by non-competitive antagonist, which is perampanel, then this is a significant kind of a control on the excitatory potentials. So even if it is available, it can't open. So this was the basic about the perampanel. So what has been found recently that possibly in long-term scenarios, it may disturb neuronal networks, oscillations, inhibit GABAergic transmission, and possible that this may have some anti-convulsant effect. In long run, may have something like an anti-epileptogenic effect also. So that is being explored. So in summary, as we know that it's glutamate is the main receptor. We do have two kind of receptor, AMPA and NMD, and most prominent is AMPA, and AMPA is the new target. So it's a novel mechanism, which can be, because it's a different mechanism, so you can combine with any available anti-epileptic drug. Now coming to the real world scenario, when we come to about the dosage and other pharmacokinetic properties, it's easily absorbed. Half-life is, sorry, not 100 days, 100 hours. So that means roughly 4 days, which is a very, very high kind of half-life, means we can easily give once a day. Protein binding is significant. Still not sure about pregnancy and lactation. And the dose is 2 milligram to 12 milligram, starting a single dose, and then you can increase slowly over a period of what now we have. Initially, we tried to increase over 2 weeks, 3 weeks, but now what we are doing is we increase only after about a month. So that the most of the side effects, which Sir Dr. Parvesh was also discussing about sedation and other things, they are more common when we titrate it faster. So giving 2 milligram and waiting for a month is the safest kind of technique. In terms of approval, it has been approved for focal onset seizures, even for the age of 4 years plus, even as adjuvant therapy, and in primary generalized epilepsies of 12 years and above. Even monotherapy has been approved in US. Most of the other countries, it is the add-on drug which has been approved. In India, if I'm not wrong, it is approved only for 12 years plus. It's possible that we may also get approval for younger age group. So the dosing wise, as we discussed, is a body dose. Whether you give with food or without food doesn't matter. At bedtime, because definitely sedation is one issue, patient do say that when I take this perampanel, immediately I get a good sleep and I need to sleep immediately. So those kind of things need to be taken care while we are giving this particular molecule. Titration we have discussed. I will prefer to give at least 4. Even if there are inducers like carbamazepine, 3 gaps should be given minimum. So if you miss one dose, that hardly matters because the half-life is quite. And when you want to taper, you can taper it slowly, because if you want to kind of avoid rebound seizure, but rebound seizure per se are very less because T half is wrong. So if for some scenarios you need to stop abruptly, it's unlikely that there will be sudden kind of status. For mild renal impairment, you don't need dose adjustment. For mild to moderate liver, you don't need to have any dose adjustment. But in those scenarios, increasing dose more than 8 mg is not advisable. So now come to the real world data. So this was one of the data, which was tried data. It is outcome, safety, and efficacy of 1 year data of patient on therapy. So in this, most of the patient had focal seizure with or without secondary generalization. And as usual, it was used as add-on drug only in the Spanish hospital. So what was found that at 1 year, there was quite a good improvement in terms of seizures. About 1/3 had response. And the best response was with patient who had secondary generalized seizures. If you see the response rate, it was maintained even at 1 year. So that is another important part. Some of the drugs may have some kind of a honeymoon period where you start drug, patients start responding, and within 2-3 months there are recurrence of seizure. So even at 1 year, that response was maintained. So in total, about 10% of patients were seizure. And these were the patients who were otherwise not responding to any antiepileptic. So the patient dose-wise, titration-wise, when it was titrated to 2 mg per week versus 2 mg 3 to 4 weeks, the side effects were definitely less. So you can see here, if you increase weekly or every 2 weeks, the chances of side effects are many more rather than if you increase after 3 to 4 weeks. In terms of concomitant anti-epileptic drug, so I'll prefer to show you this particular chart. So if the patient was on more than 5 anti-epileptic drugs, who has been given 5 anti-epileptic drugs, and perampanel was either 6 or more than 6 in number. Even in those patients, about 5% patient became seizure-free, and about 1/4 of the patient had good response. So that's what matters a lot. So if you are kind of seeing a scenario, there is no other option available after trying drug, this may be worth trying in selected patients. In terms of long-term trial, because that is important. So these were the 3 studies in the beginning, 304, 305, 306, which were the baseline studies for perampanel. And out of these 3, there was a continuation data analysis from that 307. And there were more than 1,000 patients. So outcome-wise, it was found that patient had definite reduction in seizures even at 4th year. Patient had significant reduction in secondary generalized seizures. So at 3rd year, 88% improvement in 200 patients is a quite good number. In partial seizure also, about 2/3 had response. In secondary generalized seizure, about 50% had response. Seizure-free was almost 15%. Seizure freedom from secondary generalized seizure was more than any other type. So in total, kind of scenario that secondary generalized seizures had the maximum outcome compared to other types of seizures. It has also been compared with various other drugs like lacosamide, levetiracetam, and even the brivaracetam. So with lacosamide, this particular study, it did not head on a kind of comparison. It was 2 different studies comparing this molecule. And what was found that baseline parameters were almost same. So patients were on mean anti-epileptic drug almost more than 7, while with perampanel was more than 8 anti-epileptic drugs. And despite that, you can see here, in this baseline, there were 40% of the patients who are taking more than 3 drugs compared to lacosamide. And if we compare the outcome, the retention rate was same. So that means the patient who retained lacosamide, similarly the patient who retained perampanel were same in numbers. Mean dose was lacosamide almost 400, while for perampanel it was around 8 mg. Even we see that in our practice, lacosamide we give roughly around up to 400 mg. But if you compare the response rate wise, it was 29% versus 49%, and seizure freedom was 14%, and secondary generalized were about 23%. So which gives a significant kind of a comparison-wise difference between lectrosamide and perampanel. Adverse events wise, yes, Dr. Parvesh was also saying that sleepiness, somnolence is definitely a factor with the perampanel, dizziness, ataxia. So these were the side effects which were noted. So in total, if we compare, retention rates were similar, and overall outcome wise, both were effective. Retention rate was similar, but seizure freedom and response rate was definitely higher with perampanel. So now there is a comparison with levetiracetam. So in this setting, the patient with uncontrolled secondary generalized seizures were compared. This was by Zai Pharma, so the pipe there. So response rate wise, the patient more than 75% response wise, both had almost similar response. Seizure freedom wise also, both had almost equal response. Retention rate wise, if you see, the retention rate discontinuation wise, at 1 year, it was almost ongoing treatment was 86% versus 65%. So retention was better with perampanel than levetiracetam. So in total, both had good efficacy, retention rate being better with perampanel than with levetiracetam. Next is about brivaracetam. There is only systemic review. There is a comparison with brivaracetam. And it was found that those patients who are taking levetiracetam, if you start brivaracetam versus perampanel was definitely better. So there is no head-on kind of comparison, and it is also expected that somebody who has tried levetiracetam and failed, the chances of brivaracetam becoming effective versus perampanel, the chances are that perampanel may be more effective than brivaracetam. Then there is another table on real-life experience from the European countries. And in that particular study, you can see that percentage-wise, the efficacy-wise, almost retention rate is in the range of 60 to 70%. And in this Canadian study, it was almost 89% even at 3 years. And seizure freedom-wise, it ranged from somewhere 2% to 22%, on an average 10 to 15%. And these were the patients who were not controlled with other drugs. So overall pooled analysis, 2,396%, with a retention rate of almost 50% and seizure freedom of around 9.3%. Then comes about, because most of the drugs have been tried only for focal epilepsies, so whether perampanel has a role in idiopathic generalized epilepsies, myoclonic jerks, absences, so that is a very, very important point. So in this general study, this was for the 12-month study, where other drugs used were levetiracetam, valproate, lamotrigine, zonisamide, and topiramate. So drug use was 6 milligram to 2 to 6 milligram, and 4 milligram was the commonest drug used. And if you see here, the seizure freedom wise, all seizures, GTCS, myoclonic jerks, and absences. So it was effective in absence, it was effective in myoclonic jerks, it was effective in GTCS. So that gives a very, very important point about perampanel. As in first add-on, there are some studies nowadays that it is effective even as first add-on, and it in fact it has a better seizure freedom with first add-on, almost reaching to 50%. So there are various other studies on first add-on, and some studies even where it was tried as monotherapy also. So I'm not taking those trials. I'm just mentioning these first add-on. Outcome was good. The peripheral study, again, seizure freedom was about 25%. And overall seizure freedom in these studies, this particular was published in American Epilepsy Society, it was presented. And it was found that whether it was compared with levetiracetam or valproate or lamotrigine, the effect was the same. So, and it was even at low dose, it was effective. So, in total, certain guideline wise, if you see that if you compare various other anti-epileptic drugs when we are combining with perampanel, perampanel has no major impact on other drugs, except that there can be subtle significant increase with oxcarbazepine. Other than that, there are no major changes. There is a issue of because carbamazepine is an enzyme inducer. Oxcarbazepine is also enzyme inducer, but lesser than carbamazepine. And phenytoin is enzyme inducer. So these three drugs, even topiramate, can decrease the level of perampanel. No other drugs have major impact. So it's a good choice because of long-term efficacy. When we talk about ideal drug, it should be a drug with long-term efficacy, good tolerability, good seizure freedom, minimal drug interaction, should be able to have long-term retention rate, ease of administration, no breakthrough seizures, and able to combine with other drugs. So in terms of perampanel, most of these choices are met, except side effect wise, which we'll discuss at the panel discussion based upon individual experiences. Pregnancy and lactation, there are no kind of published data on pregnancy safety wise. Some in the animals, it has been found some diverticuli of intestine and reduced body weight, but other than that, no major outcome has been mentioned in human beings. Spectrum of efficacy wise, yes, it has been published at all focal epilepsies, primary generalized epilepsies, myoclonus, negative myoclonus, reflex epilepsy, atonic seizure, tonic seizure, and absent seizure. So practically, it is being kind of advised as advocated as a broad spectrum anti-epileptic. Whether it can help in LGS, again, this was being, I think, again, Dr. Parvesh mentioned that he has used it in LGS. Yes, the outcome wise, it says that about 2/3 patients have good response in LGS. And it has also been tried in lissencephaly, mentioning that probably lissencephaly have that glutamate receptor abnormality, and those patients have better response rate compared to other drugs. In genetic epilepsies like Dravet syndrome, again, it has been tried with an outcome of 80%. In other like CDKL deficiency in patient with synaptic gap mutation, myoclonus of Angelman. So all these Lafora body disease, refractory cortical myoclonus, it has been tried in all other complicated and varieties of epilepsies. It has definitely been tried in status, and panel will discuss about this. And people have tried 6 to 10 milligram, 12 milligram, 18, 16 milligram as a bolus dose through RAS tube and found to be effective in refractory status. So the basic reason it even in progressive myoclonic epilepsy, it has been found that what we say giant potential, which we see on somatosensory rogue potential, the amplitude comes down with perampanel. So likely to be have some response even in progressive myoclonic epilepsies. So last 2 or 3 slides. So it is a drug which is affecting refractory focal epilepsy, may have remarkable improvement even in NMD encephalitis, post-hypoxic delayed myoclonus, negative myoclonus, glial seizures, startle seizures. So what is this exciting about perampanel? This is the first among the drug which have a unique molecule mechanism of action. Practically first drug which is found to be effective in all variety of seizures among the newer drugs. Effective in all varieties of epilepsy syndromes, a very long half-life. So making it very effective from compliance point of view, and no major safety issues or cognitive issues. Only thing is slow titration and start with 2 milligram, reassess at 4, even at 2 milligram, some patients have excellent response and may not need to increase to 4 milligram. At 4 milligram, just reassess again, wait for some time. You may not need to increase to 6 milligram. It has been found that when you increase from 4 to 6, the patient may have a bit of worsening and may have to come back to 4 milligram. For enzyme inducing drug, yes, you may have to give extra dose. adverse effect wise, somnolence, dizziness, headache, fatigue. These are the common side effects, and it is effective whether you give in adult or adolescents. Bedtime dosing with good seizure control. So, been kind of presented in many societies and many kind of international presentations with almost a level of evidence. So take home message, it's a new molecule, novel mechanism. It should be used because it is very effective to combine with any anti-epileptic drug, so making it a rational polytherapy. Ease of use, adherence to treatment, good safety, good efficacy, high retention rate, improved tolerability, reduced risk of interaction, and reduced cost, which has happened now. These were the kind of positive aspect of the drug, but yes, we should always discuss about the negative aspect of the drugs. And I'll be happy to learn from others' experience about side effects and other things. Thank you.
Thank you, Dr. Atmanam, for such a crisp and clear description and analysis of the molecule in your opinion, and with a lot of take-home messages that you have presented. Now we will start the panel discussion where we'll have everybody be able to speak their own experiences with this drug in the short while that is been there in Indian market. To set the tone for any discussion, the best way is to go through a case. So Dr. Pawan Sharma has gladly agreed to present a case before we start the panel discussion. So I will invite Dr. Pawan Sharma to present his case and also share his views on Perampanel. Thank you, Dr. Pawan.
Thank you, sir, for giving me an opportunity to discuss a case of a refractory epilepsy. So, I start with the case history. A 25-year-old girl with episodes of transient loss of awareness from 12 years. Multiple episodes, almost 1 to 2 episodes per day. There are multiple seizure types. Semiology is she feels some uneasiness, became unresponsive, eyes deviate to one side for few seconds, followed by some tonic-clonic jerking movement. Then she feel weak for whole day and prefer to lie down, does not take interest in any day-to-day activity. Some episodes are short transient staring look without fall. And when she came to me, she was on sodium valproate 2000 milligram and Eptoin 400 milligram. Still no response, and having such staring spells and sometimes GTCS, secondary GTCS, and very frequent, 1 to 2 per day or more than 10, 15 in a week. And she was carrying an MRI which was showing some abnormalities around periventricular areas, suggestive of band heterotopia. And these are the changes in the shapes of the, you see the shapes of the ventricles are deformed because of the abnormal ectopic cortical matter, gray matter. So MRI brain was showing bilateral nodular band heterotopia along occipital horn and lateral ventricles. EEG was also showing some intermittent focal discharges. Taking care that she was having focal seizures and focal with secondary generalized seizures, I started with carbamazepine, and keep in mind that I want to taper sodium valproate because she is a young girl. And I increased carbamazepine gradually to 1000 milligram, and sodium valproate I started tapering, but no response on reaching 1000 milligram carbamazepine. And then levetiracetam was added, considering it as a refractory epilepsy, because majority of these migration defect or band heterotopia patients are refractory, having refractory epilepsy. So I added levetiracetam and reached up to 1500 milligram per day, but still she was having 1 or 2 episodes of seizure almost daily. So she was truly refractory to levetiracetam levetiracetam 1500, carbamazepine 1000, phenytoin 400. Then lacosamide was started and increased to 400 milligram per day. She was still refractory and seizures were frequent. Then I started perampanel. It was started in low dose 2 milligram in evening, gradually increased by 2 milligram every week and maintained at 8 milligram per day. After starting perampanel, patient responded. Frequency decreased from 1 to 2 per day to 1 to 2 per month in 3 months. But patient were very dizzy and drowsy. Then I decreased perampanel to 6 milligram per day. Seizure frequency remains low and stable. Considering the multiple poly drugs, then I tried to taper off phenytoin and I tapered it without any increase in seizure frequency. 3 months later, as seizures are controlled, 2 seizures in 3 months only. Then I started slightly taper carbamazepine also because she was very dizzy and having some ataxia also. So I decreased carbamazepine to also 200 milligram from 1000 to 800 milligram per day. Seizure remain well controlled. So my message is, because earlier cost was a very hindrance in starting as an early add-on, but nowadays perampanel cost is also taken care. So I think that it may be a good to an early add-on. A few words about the band heterotopia. It's also known as double cortex syndrome. Is a form of diffuse gray matter heterotopia affecting almost majority, more common in women. Refractory epilepsy is present in nearly all affected patients, with partial complex and atypical absence epilepsy being the most common syndrome. On imaging, this condition is characterized by a band of gray matter located deep to and roughly paralleling the cortex with either normal or pachygyria overlying cortex. Majority of patients with double cortex syndrome are female on account of genetic abnormality being located on X chromosome. Condition may be familial with X-linked dominant inheritance. Seizures and delayed development are the most common presentation, usually evident within the first decade. Some patients, however, have only minor disabilities. Mostly refractory seizures are difficult to control. MRI is the diagnostic modality showing gray matter in abnormal location. Treatment is symptomatic and usually targeted as controlling epilepsy. Thank you very much for patient listening. Over to you, Dr. Praveen, sir.
Thank you, Dr. Pawan, for such a nice exploration of a case. And as we go through the discussion, we will have everybody opine about their views on this matter. But now we'll open this house for discussion with our panelists. So first, I'll invite Dr. Amit Batra to share his own experience with perampanel in his clinical practice. Dr. Amit Batra, please.
Hello. Yes.
Yeah.
Hi. Good evening, everybody. As Dr. Atmaram has already taken us through the journey of perampanel and has discussed in length about its mechanism, the unique mechanism of action it has, and also the wide spectrum where perampanel can be used. We've also started to use perampanel more often, after the introduction of the Indian version. But whatever limited experience we have with the brand Fycompa has been a mixed experience. I have encountered cases where we had difficulty in continuing the drug because of its potential of causing a lot of dizziness, and some of these patients also had falls secondary to severe dizziness. Tried with smaller dosages and gradually escalated the dose, but this remained as a major rate limiting effect. But for the group of patients who tolerated this drug well, had some good excellent control of seizures, mainly tried it in focal and also focal with secondary generalized seizure, have not ventured into using this molecule in the myoclonic epilepsy, which is a exciting area where I think all of us should be trying to use this molecule. Also had some good results in patients who had severe refractory status epilepticus, just like a topiramate, used it as a loading dose with 12 milligram. I had presented a case where we had failed on almost every drug, and we are adding perampanel, magically controlled the status, though it was a 5th or a 6th add-on, and has definitely given us a lot of confidence of its use in status epilepticus also. So as we, I think, grow with this molecule, we should be exploring the wide spectrum use in juvenile myoclonic, in absence epilepsies, and also in reflex epilepsies, post-hypoxic myoclonus. There is also a lot of literature regarding its efficacy in post-traumatic epilepsies. So I think the journey so far has been exciting, reassuring, and we need more time to explore this molecule further.
Thank you, Dr. Amit, for your views on this. And you have also shared that the horizon may be wide in the times to come as the research accumulates.
Right.
Dr. Rohan Gupta is also with us. Dr. Rohan, can we have your experience with the Perampanel in clinical practice?
Yeah, good evening, everybody. My experience is limited to the extent I hardly have a few patients on Perampanel, but my experience as an anti-epileptic agent was very good. A lot of my patients, they become seizure-free or had reduced frequency of seizures after I started them on Perampanel. But the major hindrance I had in using was, number one, was the cost factor. And number two was I had a lot of patients coming up with cognitive impairment and behavioral issues, which caused me to either to taper the dose or give them at a subtherapeutic dose maybe. So that was a concern with me. And I want to ask the opinion of the house about it. Have they had similar experiences on using Perampanel?
So we will discuss the side effects as a group together. Dr. Prateek Mittal is also with us. Dr. Mittal, what is your experience with Fycompa in partial epilepsy? So you have to unmute yourself. Dr. Prateek, you have to unmute yourself. Yeah.
Am I audible now?
Yes, sir.
Thank you, sir. Thank you so much for giving me a chance to speak in this forum. My experience with Fycompa has, especially in focal seizures and focal with secondary generalization, I've got around 4 or 5 patients in which I have used for Fycompa, and there are a few things I would want to highlight. One is I look at this drug as as an add-on medication in case of resistant seizures, on multiple anti-epileptic drugs which are not getting controlled. Wherever I have added Fycompa, results have been good. And the second thing is on resistant status epilepticus. Just like we have been using a topiramate as an add-on drug, 100 mg, 200 mg. So this there was one case in which we added Perampanel, and the response to seizure control was good, status epilepticus. Problems that we have faced is somnolence, dizziness. That's what I would want to speak.
Thank you, Dr. Mittal. We have Dr. G.P. Burman from Hisar also with us. Dr. Burman, what is your view about Perampanel in clinical practice?
Thank you, Dr. Parveen. I have used it in couple of patients. Of course, all patients are having focal seizure and refractory to traditional anti-epileptic drugs. I used Perampanel as an add-on therapy, not as primary choice, as a third choice. Patient was already in 2 drugs. Patient was on levetiracetam, and then carbamazepine was added, and still seizures are not getting controlled. Gliotic areas in brain. One patient was having immune-mediated epilepsies, autoimmune encephalitis. I added Perampanel in a small dose and gradually build it up to 3 to 4 milligram. 2 patients are getting 3 milligram at present, 4 milligram. Both are having focal seizure now. And 1 patient are already on polytherapy with 3 drugs. And lastly, I added Perampanel. And at 4th drug, that is a lady, she is getting little drowsiness, so I taper up drug little less, 3 milligram per day. With 4 drugs, now she's comfortable. Seizure frequency reduced to 1 or hardly 2 in 3 months. Keeping her in 3 months follow-up, seizure frequency is quite less. but I didn't see any these behavioral changes with low dose at 3 to 4 milligram. Although that black box warning in US, this Perampanel, this box that severe behavioral changes, psychosis, suicidal tendency, and agitation, even homicidal ideation has been reported with Perampanel. Only one young boy is having some behavioral changes, but as and when I reduce the dose, that part is okay. I have a question for Dr. Bansal, Anwaram Bansal, made a very nice presentation. I listened to a lot of lectures previously also. I want to know this, what you mentioned, that real world data, and perhaps you have mentioned real world evidence also, RWD and RWE. So how it will help you for while supporting regulatory decision for a medicine, keeping aside RCT. RCT perhaps is the gold standard. So how will you rely on these RWD rather than RCT? Perampanel is concerned, or any drug is concerned.
It's I'm not the expert about these approvals and other things, but because studies have been done to the class A evidence, at least for the add-on point of view.
Yeah.
Okay, so that's the reason that FDA and US it was approved. But I'm not expert to comment on our real world data versus real world evidence on and approval from other point of view.
I think real world data are not very conclusive. They are retrospective data, and you are not doing any control trial with the drug. So though I think you are in the Bangkok Congress also, Epilepsy Congress, these data were published and presented in Epilepsia and subsequent in Bangkok Congress. And there are a lot of criticism that real world data perhaps are the not the real evidence to rely on regulatory approval for a drug like Perampanel, which is having good amount of behavioral side effects, suicidal tendencies, so on.
So I think we can discuss each other's experience about adverse events, and we may learn from it.
Yeah.
So that may give us a real, not only real world data or real world evidence, but a practical kind of evidence from it.
Absolutely. So now let's talk about the adverse events, especially general and psychiatric. So let me invite Dr. Rajshekhar Reddy to give his views and experience about the real-time side effects and the problems that you have in the usage of Perampanel, and how do you mitigate them?
Thank you, Dr. Praveen, and very happy to be here today. And it was a fantastic lecture, as always, by Dr. Atmaram Bansal. The slides were very nicely presented, and the simplicity is important. That's, I think, that's the important message today. So a couple of things. First of all, I think that all of us realize that there is already enough space to get more and more drugs. I think we need more and more add-on drugs. And like he said, that there have been about 17 additions in the last 35 years. So there have been more and more drugs which have been added. And I think that that is still going to be a requirement. So this drug is a welcome addition to our armamentarium. In terms of the downsides, the first thing is, of course, we worry about sedation. So the recommendation is to give it 2 minutes before you hit the pillow. So I always tell my patients, take it 2 minutes before you hit the pillow. The second thing is that the start low, go slow problem with this drug. Now, when you're doing that, and if you're going to increase it over 3 to 4 weeks, which is the best way to do it if you want to mitigate side effects related to dizziness, etc., then there are chances of breakthrough seizures happening, unfortunately. That is not often discussed, and I'm not very clear about what kind of data we have for that. But if a patient is on a particular drug and continues to have one odd seizure, they may lose confidence in the drug. The third problem, which is always there with any new add-on, any new agent, is that we invariably add it downstream, which means that we've already given 2 or 3 drugs. And these are patients, in case if you're adding it as a third drug or a fourth drug, these are already difficult to treat patients. So sometimes you don't get that great results in these. And so one of the ways is, if you want to really know how a drug works, is probably to use it as a first add-on and see how that works for us. Also, it's going to be concerns regarding women of the childbearing age group. So all our, so-called primary generalized seizures in which we want to give young women this drug, we still do not have enough data. But I think that will evolve. There will be pregnancy registries that will come out. There will also be a situation where it will start being used for younger and younger children. And that's what we see normally happens. You initially get an approval for 16 years and above, then it becomes 12 years, then it's 4 years. And before you know it, pediatricians are giving it as a syrup for, 6-month-old babies also. We'll start seeing prescriptions of that. So that's, I think, the usual evolution. In terms of the side effects, I think they're all, anything that is acting on the AMPA receptor is going to have psychiatric side effects. And though this is not, it's causing a conformational change of the receptors, and the glutamate can't overcome that, but still that is the receptor through which we are going to get psychiatric side effects. But interestingly, out of the glutamate receptors, most of the side effects related to hallucination, agitation are through the NMDA receptors, not so much the AMPA receptors. So that way, this drug at least only acts on that. So that would also eventually, I hope that in the future, when we add this drug, so the concerns would be to add it to a drug like levetiracetam or brivaracetam, where also there is psychiatric comorbidity. We know that, which increases in these groups of patients. So we'll have to see in these patients how it acts. But in my experience so far, I could go on about a case, but I think for want of time, I wouldn't do that. But I think that it's a good addition to our armamentarium. Still a start low, go slow drug. But I think as a first add-on or a second add-on, in the next few years, we'll start using it more and more. Thank you.
Thanks, Dr. Reddy. Dr. Manish Mahajan, would you like to add something to your experience about side effects and mitigating them?
Thank you, Praveen sir. I think most of the things have been discussed by Dr. Reddy and my previous panelists, because this is the one thing which dizziness and somnolence have been the most common problem, and since we have been adding them as the second or third add-on, not as the first add-on, so yes, and starting slow and going slow in the titration has been definitely a challenge in controlling the seizures earlier on, and especially with the more so with the carbamazepine, we had a challenge if that has been already one of the anti-seizure medications which has been already on. The one thing which I think we had a discussion earlier also in one of the panel discussion we had on Perampanel, I would like to highlight that one of my patients which I discussed about the status use of Perampanel in status epilepticus, right over there at levetiracetam with valproate and levetiracetam both had caused significant this thrombocytopenia. So, but and again carbamazepine was a challenge adding on with the cytopenias happening. This was a person with a hematological malignancy already. So with the bone marrow suppression happening, we had a very good experience with Fycompa being used in this patient. So obviously this is like offline for the thing, but out of my experience with Fycompa and the Perampanel, this was something which was really worth noticing, that we didn't have any cytopenias with this drug, but definitely seizure control was a good achievement. Behavioral side effects, obviously, if we really go slow, are very infrequently encountered in the real world, I would say.
So Dr. Manish Mahajan feels that if you go slow and don't go very high, you may not have as much behavioral side effects as we are usually afraid of. We have Dr. Birender Paul with us from Ludhiana. Dr. Birender, what is your experience in combining Perampanel with other psychoactive drugs like levetiracetam, brivaracetam, or maybe topiramate or zonisamide in terms of usage? Have you tried combining these drugs, or have you refrained from them?
Thank you, Dr. Praveen. I think it was a great discussion regarding the Perampanel. In our experience, we have almost 4 patients of status epilepticus which were not controlled with any other drugs. When we started adding the Perampanel to them, although we titrated it quite fast, but we found there was added advantage in controlling the seizures. Secondly, regarding the use of perampanel with other with drugs which have as psychiatric side effects. But I think, but in our practice, what we have done when we added perampanel with levetiracetam or other drugs, although what happened that when the seizure got controlled, we started reducing the dose of these drugs. Although we are not able to stop these drugs, but when we reduce the dose of these drugs, it has been seen the psychiatric side effects, they become less once you start reducing the dose of these drugs. So this was the added advantage, because another thing is that perampanel act through different receptors. So as highlighted by Dr. Atmaram, this gives an added advantage of using with any other drug. And this will not augment in the side effects which we see as a calcium channel drugs which have calcium channel blocking properties or sodium blocking properties. The only problem which we see when we use this drug is we have to titrate very slowly. So for that we have to counsel the patient regarding that it might be possible that it may take us 1 month or 2 months to control the seizures. Because in those patients, whenever we have titrated, either they were because of the patient left the drug, or we are not able to achieve the target which we wanted to achieve. But when we start titrating it slowly over 3 months, then the response was very good. So this was our learning thing, that we counsel the patient first regarding use of this drug. So this is what we wanted to share.
Thank you, Dr. Paul. Dr. Prabhakar, your view on side effects of perampanel that you have experienced in your clinical practice, and any ways to reduce this?
My personal experience.
Hello.
Hello, yes, sir.
Haji. Thanks for the questions. I think it has been nicely discussed. Various problems have been discussed. My experience is with 10 patients. Out of the 10 patients which I gave, 4 responded very nicely. Other 5 patients had not very good results. But one patient in whom I had only gone up to 4 milligram, that he became so hyper, and he became a manic person, and I had to stop the medicine in that. So not a very large experience, but definitely you can say 10% person when I had to withdraw the drug and stop it. In others, the patients did not want to go beyond 6, and because the cost factor was also there, so only 50%, let us say, they responded. But we were doing 1 weekly increment. So maybe when we do it monthly increment, those other 4 groups who did not tolerate the drug, maybe that would be better with the passage of time. When we try now, after having learned that maybe 1 month titration is helpful.
Thank you, sir. Dr. Parvesh Shah, your opinion on the side effects and problems with the use of perampanel?
Yeah. Thank you for this question. The main side effect which I encountered in my patient, I have experienced with 7 or 8 patients. The main side effect with these patients is the sedation. And in one patient, I got this air discharge. And that time I wasn't aware, but later on, once going through the literature, I came to know it can cause otitis-like picture, otitis media-like picture. But that was encountered in one patient. But the main side effect main adverse drug reaction was the sedation.
Thank you, sir. So, Dr. Anshu Rodgi, we've heard Dr. Atmaram speak about how it is useful in generalized epilepsy and how people are broadening the horizon by presenting some small data in myoclonus and other syndromes of epilepsy. Do you have any experience of using perampanel outside partial epilepsy in patients of resistant generalized epilepsy or some other forms of epilepsy? Dr. Anshu Rodgi, please. Anshu, are you there? So while Dr. Anshu joins back, Dr. Sushma Sharma, do you have any experience of using Perampanel outside?
Yeah,
Sir, you're here. Yes, please.
Praveen,
Yeah.
Batao Praveen.
So what do you have any experience of using Perampanel outside partial epilepsy in patients of resistant generalized epilepsy or patients of resistant myoclonic epilepsy or syndromic epilepsy, like the evidence that was presented?
Yeah, so first I will start that Perampanel is also very good in patients who got refractory and super refractory status. In fact, we have used in a number of patients, and we start with a loading dose of about 12 to 16 mg, and we give it through the Riles tube, and it works really well, especially patients who have focal with secondary generalization. It works well. So that is one area I think we have found it to be very useful. Of course, in patients who have got very difficult to control epilepsies or even LGS, Lennox-Gastaut, it works well. And I feel that it's a very broad spectrum drug. And the beauty of the drug is that it has a very different mechanism of action. So you can combine with various kind of drugs, very different kind of drugs. So, and I think that the focus is now shifting it to being used as a early add-on, rather than, because previously when it started, we were using it the fourth, the fifth drug. Now we are trying to use it as a second or a third add-on. I think that is important because if we start early, we will have a better seizure control.
Thank you, sir. Dr. Sushma, do you have any experience of using Perampanel in generalized epilepsy or other forms of epilepsy apart from partial epilepsy?
Yes, Dr. Praveen, certainly I would like to share that I have used Perampanel in around 30 to 32 patients so far. And I have used it in a wide range of epilepsies. I have used it in, of course, in focal seizures with secondary generalization, including medial temporal lobe sclerosis, neurocysticercosis associated seizures, tuberculoma associated seizures, viral encephalitis associated seizures, as well as tuberous sclerosis associated seizures. I have used it in generalized epilepsy also. I have used in juvenile myoclonic epilepsy, where I have also used in a male patient as a first add-on with good response and at a 4 mg dose. I have used in G1 syndrome also in a child with a heartening response actually. And I have used in status epilepticus as well. I have not used in convulsive status epilepticus, but I have used in non-convulsive status epilepticus due to viral encephalitis, due to subdural hematoma, and in post-traumatic, post-head trauma non-convulsive status epilepticus. I have used dose up to, in non-convulsive status epilepticus, I have used 8 milligram as the loading dose. I have used in some special situations like liver disease, like alcoholic liver disease, with end-stage cirrhosis. A patient was also having multiple neurocysticercosis and refractory seizures, and the choice of drugs, of course, was limited. I have used in post-renal transplant patient also. Yes, I have used in varied clinical situations, including generalized epilepsies. The usual dose that I have used is 4 milligram in most patients, and in a few patients I have gone up to 8 milligram also. I haven't had to use 10 to 12 milligram in any patient. So that's my experience with Perampanel. I have used in a child. Yeah, I have used in. I'm sorry, just to complete. Yeah, I have used in a child. The minimum age at which I have used is a child of 4 years of age who was having a non-convulsive status epilepticus due to a neurocysticercosis, and levetiracetam had been given, and lacosamide also had been loaded, and yet the child was continuing to have a non-convulsive status presentation. And addition of Fycompa did circumvent that problem. And now the child is on 3 drugs, levetiracetam, lacosamide, and Fycompa. And for last 8 months or so, he's doing fine with no breakthrough seizures. And the maximum age that I have used, the eldest age would be around 60 years where I have used. The problem of course, the load, the cognitive side effects and sedation, as Dr. Atmaram Bansal said, the trick lies in starting low and going slow, and keeping the dose as much as required only, and not to increase too fast, and giving time at each dose and seeing whether the patient would respond or also. There would be some patients who would not respond to Fycompa, but wherever it works very well.
Dr. Atmaram, you presented the data on being using in various syndromic epilepsies and generalized epilepsy. Have you yourself used this drug in syndromic epilepsies or generalized epilepsy? Atmaram?
Yeah.
Yeah.
So recently I have started using it in patients who are having refractory juvenile myoclonic epilepsies. And I must have used only in 2 or 3 patients, and yet to know about the long-term outcome, but none of the patient has any adverse events.
That's very heartening. Because we may have a lot of patients of JME, some patients, 15-20%, who may not respond to conventional drugs, or they may have side effects, and we also need sometimes options in those patients. Dr. Sahil Kohli, we have Dr. Sahil Kohli with us. Dr. Sahil, what do you think is the add-on? You use it first, second, third, late add-on. What do you think is the place of Fycompa or Perampanel in add-on therapy?
So very good evening and very detailed talk by Atmaram sir. Sir, I actually have used it only as third or fourth add-on, and I have had mixed responses with that. Because first one, because of the cost, the other because of the sedation and other side effects. But one case which I want to discuss and share your views on that. One lady, there was a young girl, 25 years, who had a strangulation and she had a hypoxic injury to the brain. And while recovering, she was fairly okay, but she was having disabling myoclonus. And when she used to try to walk, even touching the foot on the ground, she used to have a reflex myoclonus and she would fall. She was already on valproate, full dose of levetiracetam and clonazepam. But then I searched some literature and found that Perampanel has a good role in myoclonus. And after I started, that time I had gone almost 8 milligram twice a day over a period of 3 weeks. But she responded very well to that. And she almost started getting back to her work, and with minimal support, she was almost doing her daily activities daily. But yes, after this, hearing this talk and hearing this discussion, I am very keen to see how patients respond to this as a second line agent or a early second line agent. Yes, sir.
Anybody who would have experience in syndromic epilepsies with Perampanel? So let's rewind again. So Dr. Amit Batra, what do you think is the ideal patient or place in therapy for Perampanel for you?
So definitely now, as you discussed, I would want to use this as an early add-on in a patient who either has a focal epilepsy and also would want to try it in primary generalized epilepsies. So some patients, definitely we would have to start it early, because we've already had cases where we've used it as a fifth or a sixth add-on. But now if a patient has already failed on levetiracetam or say brivaracetam, I would want to use it as a first add-on.
Thank you, Dr. Amit. Dr. Rohan, what do you think? Does Perampanel have a place in therapy of your patients?
I think Perampanel is a wonderful drug, but the major limitation being that you cannot use it as a first line, because the time to titrate would be pretty long, and patients don't have that kind of patience to be waiting for such a long time. So maybe as a second or as a third add-on, maybe we can use it.
Yeah. From the audience, there are 3 questions. So we'll take up these questions also as a part of the discussion. Dr. Atmaram, the first question is, because of its anti-glutaminergic activity, do you think this mechanism of action allows Perampanel to have a role in other degenerative or other neurological disorders also?
So actually, most of other neurological disorders involve NMDA receptor more than AMPA. So unlikely that Perampanel may have effect on those diseases, but certain diseases do have AMPA receptor antibodies. But in long run, whether that will have some effect on primary pathology of those diseases, difficult to say. There are no trials or no approved other than just epilepsy.
Another question that has been asked is, what is the mechanism of action of psychiatric side effects of Perampanel? It is believed that the psychiatric side effects of perampanel are caused by its action on AMPA receptors. In fact, with levetiracetam, which is actually a SV2 drug, it is believed that the mechanism of large amount of psychiatric side effect is action on the AMPA receptors. And brivaracetam differs from levetiracetam in the way that doesn't act so much on AMPA receptors. And that is why it is supposed to have less psychiatric toxicity. The third question is, and I'll have Dr. Sudesh Prabhakar please answer that, is what do you think would be the role of perampanel vis-a-vis the other drugs that we have, like newer drugs like lacosamide and brivaracetam, and how about combining these drugs?
I think after listening to the whole panel discussion, the two things become important. One, that it is a good molecule. I would definitely try to use it early, but not as a second add-on, because we have to still see how the things really go when we use it. And I would prefer personally as a third add-on rather than as a second add-on rather than as a first add-on. This is one part. As compared to the other drugs which we are using, I think this is going to be better tolerated, and leaving aside the time taken, that is 2 to 3 months before we reach a actual dose. Otherwise, this is going to be a better drug than even lamotrigine. Even lamotrigine takes 2 to 3 months. You cannot give it so fast. So I think it will be a better drug as compared to the other ones.
Dr. Parvesh, your opinion on comparing perampanel with the other newer anti-seizure medications like lacosamide and brivaracetam, and whether you have combined the newer drugs together in your practice?
No, I have not combined. So far as brivaracetam is concerned, it's a new molecule, and as per literature, we can combine, but there is no data available whether there is drug-to-drug interaction or not. But regarding brivaracetam, there we can chance of sedation are less as compared to Fycompa. That's the main advantage of brivaracetam or this Fycompa. That's the main side effect. But as of now, the experience is limited with brivaracetam as well as Fycompa.
Thank you, sir. Dr. Rajshekar Reddy, what do you think would be the place in therapy for perampanel in your patients, and where would you like to use in which patient population?
So I think that because it's a novel, sorry, let me just get my video open. So I think it's a novel mechanism of action. So first of all, I think that's an advantage. It's very different from all the other drugs that we are using so far. So whenever we're trying to control difficult to treat epilepsy or difficult, to control epilepsy, invariably we're looking at multiple mechanisms of action. Theoretically, that is very appealing. So we know that here we have one of those drugs which is postsynaptic, which is affecting a particular receptor, which is completely different from other drugs. And except for the places that we are worried about drug interactions, such as carbamazepine or oxcarbazepine, and the other combinations that should work fine. And I think that, I would probably, like Sir said, Dr. Prabhakar said, you would want to probably think about it as a second add-on. But I think in certain cases, you might even consider it as a first add-on. Like I said, the more downstream you use it, we're going to have more difficulty controlling seizures with these drugs. And sometimes if you want to know the true value of agent, you want to probably give it a little earlier. And maybe you won't need to give a very high dose of the drug. So that's another thing that I think will happen when we give it earlier rather than later. So hence that will also mitigate some of the side effects that we're concerned about in terms of sedation and things like that. If you can manage with a 4 milligram dose rather than let's say an 8 milligram dose, that would be an advantage to us.
Dr. Anshu, there has been a lot of talk of amount of seizure freedom that perampanel brings as compared to just control of seizures. So what is your opinion on the importance of seizure freedom in choosing perampanel as a drug above other drugs? And your view on the role in therapy of perampanel? Anshu, please. So in the meanwhile, that Dr. Anshu joins, let's move forward. So let's move to Dr. Who can I say? Dr. Sahil, what do you think is the place in therapy for you for Perampanel after this discussion?
So I think we will start use. I think in my practice will be putting more patient at least on second line agent. And what other thing is that I have to titrate slowly.
Okay. Dr. Manish Manjan, do you think seizure freedom is an important aspect of a drug, and do you think that allows this drug a special place in therapy, or what is the place in therapy for Perampanel in your practice?
Dr. Praveen, I think, sir, the seizure freedom is always a target and it's a goal, because I think seizure freedom is something which will reduce the risk of SUDEP, which is considered to be the most important, I think, mortality parameter for the people with epilepsy. Now, very importantly, I think the additional advantage where Perampanel scores over the others is the once daily dosing, and as Dr. Atmaram sir, Vansal sir very rightly highlighted, that in case we have a chance that where there is a probability that patient might skip one dose or the other, then there is less likelihood of getting a breakthrough seizure with single skipping a single dose of the, which is a very common, I think, experience with all of us, that people skip, especially the kids and the so with other drugs which are at least to be used as a twice a daily dosage, and this drug holds a good promise in that. And after phenobarbital, I think this is the one drug which is this much long half life, so and such a broad spectrum of anti-epileptic this coverage. So I think this is the good part of this. I think it has got a good promise. It's since now the cost factor has been taken care of, we find more wider usage. Only thing is that it is an oral, only available as an oral preparation, the others being now available as the IV preparation also. So that's the only thing which is, I think, stopping us from using it, as Dr. Anshu also highlighted, that it has to be given through the Ryle's tube. So in the cases of status where other drugs can be, now even brevesetam is being available in the IV formulation.
Dr. Pradeep Mittal, do you think this discussion actually makes you feel that you should try and use Fycompa or Perampanel in a different way in your clinical practice?
Am I audible, sir?
Yes, sir, you are.
Sir, I think we've got a very good drug here, which gives us a leverage on one is resistant seizures. So the inhibiting factor is side effects, and I think it's a very good add-on drug, probably second add-on, not first add-on, looking at the side effects and looking at the availability of other drugs, which should be tried first, I believe. One thing I wanted to highlight, sir, is a case in which I had used Perampanel. This patient had difficulty in sleeping. He was an alcoholic. He did away with his alcohol, but he had seizures which were probably not alcohol related, and he had resistant seizures. So he had I had given him a trial of valproate and levetiracetam as well. Seizures were not controlled, and this patient was unable to sleep. So the option I had was clobazam, and the other was Perampanel. I used Perampanel. Seizures got controlled, and this patient used to sleep. There was no underlying depression in this case, which was causing insomnia. So it's got a very good potential for patients who have got resistant seizures, especially to at least two drugs, which have been two good drugs like valproate plus levetiracetam or lamotrigine, which has been tried. So it's a good add-on drug here. And second thing I'd want to highlight is, okay, there are side effects, but some patients we can really use these side effects also. Of course, we have to see in the background whether there is any underlying depression or psychosis which is causing this lack of sleep. Apart from that, it's a very good drug, provided we use it as a second add-on.
Dr. Anshu, are you there now? Dr. Anshu, sir? Ranchu, are you here? Please unmute yourself. So, Dr. Burman, what do you think is the place in therapy for you in your patients in the population that you see for Perampanel? Dr. Burman, is he there?
I think we are reaching almost the end of the meeting.
Yeah, so that's why. So we'll just wrap it up. Dr. Sushma, you have used Perampanel in a large number of patients. What do you think is are 2-3 key features that make you choose this drug above other drugs?
I have, you asked me about the features that make me choose this drug above other drugs.
Absolutely.
I think one is that it can be combined with any drug. So that is one thing. You don't have to think whether this drug goes with this or not. Regarding combining, the one concern was raised about combining it with levetiracetam, whether that would potentiate the behavioral adverse effects. I have combined it quite often with the levetiracetam actually. And I think if levetiracetam per se has not caused any behavioral adverse effects, though it is only an anecdotal experience, but I think if levetiracetam has not caused any behavioral adverse effect in a patient, then addition of Perampanel would not make it to cause those behavioral adverse effects. Perampanel's own behavioral adverse effect, of course, I think it is not an additive. It may not be an additive effect. Second is, one is that it can be combined with any drug. Second is its safety in liver and kidney diseases. So in liver disease patients also we can give up to 8 milligrams.
So on the basis of this data.
Hello?
Hello, yeah, ma'am.
Yeah, there was some, voice coming. Second is that in liver and kidney disease patients also we can give and there is not much problem. Third is the dose is very, dose is straightforward. Even in children, the dose remains the same. And fourth is that it has a wide spectrum. It can be used in all kind of epilepsies. Fifth is that it is once daily dose. Sixth is that the milligram is very small, and that is psychologically very, appealing to the patient, that they are, although it is not a scientifically valid point, but psychologically it is very appealing to the patient to take a drug which is only 4 milligram, only 6 milligram. So that is another thing. So, and of course, the most important thing is that I have seen it working. I have also, like all others, I also agree, I have mostly used it as a second add-on. Mostly used as a second add-on, except for 1 or 2 patients where I have used as a first add-on, but mostly I have used as a second add-on. And another good point is that it can be also used in status epilepticus, and where it works really well. Where it doesn't work, there will be some patients where it doesn't work, but when it works, it is a very heartening response. So those are the things.
Thank you, ma'am. Dr. Anshu, do you think seizure freedom is a very important aspect of Perampanel in your patients? And what are the patient population you would be happy to use Perampanel as first add-on, and what are the patient population you would want to avoid? Dr. Anshu, please. So
possibly some network issue or something.
Dr. Atmaram, what are your closing remarks? Now we are about to the end of time of a very, very hardening discussion on a drug where we have views from all aspects. What are your closing remarks, if you have to add any on Perampanel and its use in closing therapy?
Just to kind of, from my side, I'm using it easily for last 3 years, and my personal experience will be almost 100 cases now. So out of these, about 10 to 15% patients who were not responding to any drug became seizure free while giving this Perampanel, which is a reasonably good percentage, considering the fact that those were the patients who were not responding to any major anti-epileptic drug. In terms of retention, most of the patients retained other than related to a kind of a post in the past. And we hope that now that should not be a big factor. And starting with 2 milligram, maintain it, don't increase it for a short period, just wait. Even at 2 milligram, patients have excellent response. And status, yes, bolus 8 to 16 milligram is one thing we should try. That's what I can say.
Thank you, Dr. Atmaram. Dr. Parvesh Shah, your closing remarks on the discussion and Perampanel.
Firstly, it was a wonderful discussion. All the participants shared their experience regarding this new molecule. As of now, I think this is a promising molecule as an add-on therapy, and I agree with most of the panelists that we can use it as a second add-on therapy, not as a first add-on. And regarding its untoward effects, especially the somnolence and sedation part, as Dr. Atmaram mentioned, we can take care of it by starting low and going slow. We should make increments at monthly intervals rather than making weekly intervals. So that way we can take care of it.
Thank you, sir. Dr. Anshu, any pearls of wisdom that you would like to share in usage of Perampanel in your practice? Any special patient group you would use and special one that you would avoid?
Yeah, I would, first thing, I would usually, my best experiences with patients who have got focal with secondary generalization. They are the group, I think Dr. Atmaram must have spoken about that the patients with focal with secondary generalization, they do the best with Perampanel. And this first thing. Second thing is that we should try and avoid using it with levetiracetam because of the psychiatric comorbidities, because it's going to increase the psychiatric side effects. So in patients who are already on levetiracetam, we should try and avoid Perampanel. So I think these are the two very important things. And second is always starts with a small dose and goes very, very slowly. And if the patient is not responding to 8 mg, he or she is unlikely to respond to Perampanel. So you should try and taper off the drug. If after 8 mg, it is not going to work. And I think the most common side effect is again sedation, somnolence, dizziness, and irritability. Irritability is a problem in some of these patients. So I think these are the most common things that we would see.
Thank you, sir. Dr. Prabhakar, what is your final view on Perampanel? We have had a long discussion on it.
Well, thank you, Praveen. I think, first of all, I must congratulate you. You did a marvelous, good job in very nicely moderating this whole session. Congrats. Nicely done.
Thank you.
I think it has already been summarized. There's no need to repeat again and again. It is a good molecule. It is a molecule which we should try as a second add-on drug. We have to see our experience when we give with levetiracetam or without levetiracetam or with the brevactam. Our own experience is going to tell us whether we want to add, because we were told that not much effect was seen when it was given with levetiracetam. All of us, maybe in 6 months or 1 year, are going to have our own experiences, and we will know what happens and where it happens. It's a nice thing to know that we have got another armamentarian with us for status epilepticus. It's a good thing, even though we have to give through Riles tube. But if we can help patients with super status epilepticus or refectory status epilepticus, as we were told, I think it is a good thing. Thank you very much.
Thank you, sir. See, I would think that if we had combined the data that we all of us have of use of Perampanel in status epilepticus, we would have published more cases than that exist in literature in today's date. In fact, if you see, most of the series are small, and some of us pulled together could have put a series which was better than them with experience in our own patients. We heard a adage called where it works really well, and where it doesn't work, it actually doesn't work. So I would agree, like some of the studies showing that brings about sudden seizure freedom in some patients of refractory epilepsy, and where it works really well, especially in certain cases of status where most drugs have failed, and there is a logical explanation of how GABA receptors are internalized and AMPA receptors are become very important receptors, especially in patients with autoimmune encephalitis and such. So I would agree it's a good drug and has a special place for certain patients of refractory epilepsy, and may be valuable as an early add-on also. So with this, I will hand over this seminar now to the Intas Pharma after a very, very ravishing and fulfilling discussion with all the panelists, chairperson, and the speaker.
Good evening, doctors. On behalf of Intas Aestheta Division, I would like to thank you, Dr. Atmaram Bansal, for your excellent insights on Perampanel role in the management of uncontrolled seizures. Our sincere thanks goes also to you, Dr. Praveen Gupta, who has excellently moderated today's program. I wish to thank the chairperson, Dr. Prabhakar and Dr. Parvez Shah, who has showered us with the opening comments on the key observations of the molecule. Today's webinar, True Learning, of this program would not be complete without hearing the rich experiences of our eminent galaxy of panelists, namely Dr. Anshu Rotagi, Dr. G.P. Burman, Dr. Rajshekhar Reddy, Dr. Sushma Sharma, Dr. Pawan Sharma, Dr. Amit Batra, Dr. Sahil Kohli, Dr. Manish Mahajan, Dr. Pratik Mittal, Dr. Rohan Gupta, and Dr. Birinder Paul. I would like to thank the more than 300 participants of today's program who has joined us for this program and helped make it a grand success. Thank you to all of you. Wish you a wonderful week ahead. Thank you, sir. Thank you to all.
Good night, everyone, and stay safe.
Good night. Good night. Good night.
Good night.
Good night, sir.
Okay, thank you.
Good night, everyone.
Good night, sir. And thanks a lot, Dr. Praveen and Dr. Atmaram.
Thank you.
Thank you very much, sir. Good night, sir.
Good night, sir. Suresh, sir. Suresh, good night, sir.
Good night.
Pratik, sir, thank you so much. Thanks for this wonderful evening, sir. Thank you so much.
Thank you, sir. Thank you, Dr. Prabhakar.
Thank you,
Thank you, sir.
Rohan, sir, good night, sir. Thanks for this wonderful evening.